I just want to thank you very much for your time and Foot Innovate. Certainly appreciate Lisa's assistance with this. I am Dr. Kirk McCullough. As far as the other presenters I'm going to be working with, first off, Dr. Martin O'Malley from Hospital Special Surgery. I'm an associate professor of orthopedic surgery at the Weill Cornell Medical College, as well as a team physician for multiple entities, including the Brooklyn Nets, USA Basketball, and Iona College Athletics. He's going to be lecturing to us about lateral and posterior malleolar based injuries in the elite athlete, Dr. Robert Anderson, who's the director of foot and ankle at Titletown Sports Medicine in Green Bay, Wisconsin, and is a team physician for the Green Bay Packers, longtime team physician for the Carolina Panthers as well, and a co-chairman currently of the NFL Musculoskeletal Committee. And then myself, it's the Orthopedic Institute here in Leawood, Kansas, and Kansas City, a member of the NFL Foot and Ankle Committee, along with Bob, a team physician for our MLS and USL teams. And just appreciate you all and your attention to the, as far as what we had mentioned, ankle fractures in the elite athlete is going to be the first talk by Dr. Marty O'Malley. We're going to follow that with Dr. Anderson talking about medial-based injury in the elite athlete. And then we'll follow up then with syndesmotic considerations regarding injuries, both with fracture and with syndesmotic sprains alone, and then have an open case discussion and question session at the very end. And so with that, we will then switch back to Dr. Marty O'Malley, who will begin our lecture topics.
Thanks, everyone, for joining us on this Tuesday evening. What I thought I would do is, as I am not a traumatologist, but I've been treating ankle fractures for now 25 years. And I thought I'd share with you a little bit of how I've changed, how my practice has changed over the years. And it really revolves around the posterior malleolus. I haven't really changed the fibular fracture. I use a lot of antiglide plates. There's a variety of different plates now for foot and ankle fractures with the locking plates, and they're all very effective. The real controversy for me for the fibular fracture really goes back to Bob's talk was on the medial side, whether or not to repair a deltoid, and the tendency sort of over the years that we've gone now to really repair the deltoid more often than not. But in terms of the ankle fractures I see in the athletes, what I've seen is that they're big guys, they're moving fast, there's a lot of torque involved, and I really have seen a tremendous number involving the posterior malleolus. And that's what's changed, because early in practice, when I was a resident early attending, you'd have to try and find a reason to fix the posterior malleolus, and people would say, "Oh, you don't need to fix that. It's 25%," and they had all these crazy numbers that didn't make any sense, but they became dogma. And so I think the controversies now is the posterior malleolus, and going with that, the use of a CT scan to evaluate all these fractures. Also, how far up we fix a proximal fibular fracture. We'll talk just a few minutes on the role of arthroscopy involving these, and then we'll all chime in on the post-op regimen and return to play. So the old rule of less than 25% is wrong. We know that the posterior malleolus is involved in 40% of ankle fractures, and we know it's difficult to visualize on plain radiographs, especially this posterior medial fragment. You can't see it at all. We also know that the posterior malleolus is probably the involvement of the posterior malleolus is probably the most, besides anatomic alignment, involvement of the posterior malleolus is probably the biggest prognostic factor for post-traumatic arthritis. So you really need to address it and not try and ignore it. So, if you look at the reliability of radiographic assessment on the posterior tibial malleolar fractures, only the size of it can be measured reliably on a plain X-ray. So standard care for us has really been CT scan. Everyone gets a CT scan on pretty much every ankle fracture, because we are finding more posterior plafond fractures than we ever thought. I'm fortunate that we have a weight-bearing CT scan in our office, and so you come in a cast now, you go right, and you've broken your ankle, you go right in the scanner. And we've been shocked at how many cases we would have missed just by doing plain X-rays. There's a good study of China, which is interesting in that they did 6 measurements. They did plain X-rays, axial CT, sagittal CT, 3D CT. One of the funny things is the lowest inter-observer reliability is between the chief resident and the attending surgeon using plain radiographs. So those are the two who disagreed the most. The residents were all pretty much on the same page, and improved almost perfect with 3D CT. So the existing operative indications, which are determined based on plain radiography, are neither reliable nor suitable or other measurement methods. So all the things we learned before sort of have to be re-examined in light of all this data on the posterior malleolus. Another thing that was sort of interesting preparing for this was sort of this guesstimation of posterior malleolar fractures on a lateral radiograph. And in fact, you a little bit, you overestimate how much articular involvement is compared to weight-bearing CT or a 3D CT. So the diagnostic accuracy of measurements on plain lateral radiograph was 22%. So the message is, here's an X-ray on the left, here's one on the right. You don't see that medial fragment at all. You wouldn't even know it was there. And they're hidden, and get a CT scan on all your ankle fractures. There's another kid who came to see me. He's a Division I basketball player, landed, getting a rebound, and, kind of a bad looking bimal, probably a trimal in the back. And then you get the CT scan and you see it's like 6 pieces in the back of the kid's ankle, 3 pieces medially, a piece interposed piece. And so you have to be comfortable doing the posterior lateral and posterior medial approaches. The posterior medial one is often a little bit anxiety provoking. Posterior lateral is pretty simple. We go between the fibula and the Achilles tendon, cut right down. You'll find the sural nerve, retract out of the way, and you approach find the FHL, and that gets you the posterior lateral. The posterior medial is a little bit more anxiety provoking for people who don't operate back there. I usually make it right over the neurovascular bundle and keep the neurovascular bundle posterior and the FDL and posterior tib anterior to my approach. So there's been a whole classification system. Haraguchi did it in 2006, and he categorized these posterior fractures into 3 types. Problem is, it really didn't have a prognostic. Mason did this in 2017 in foot and ankle, and this is really good work they've done. And they followed up this even recently with a study, and I'll get to a second, about the posterior tib fib ligaments. But the primary fracture line were characterized into 3 groups. Type A was described as a small extra-articular posterior malleolar primary fragment. B was there's a 2A and 2B was sort of in the Volkmann area, and type 3 was sort of a coronal plane fracture involving the whole posterior plafond. And what's interesting about this 3-dimensional picture, seeing this as a type 1, type 2, and type 3, was some of the anxiety is, well, if I fix this posterior malleolar fracture, do I need syndesmotic fixation? And 2, what percentage of these posterior malleolar fractures involve syndesmotic fixation? I could jump into Kirk's talk, but if you look at this, the interesting ones are these 2Bs, in that really it's a rotary component. And you get this posterior piece, and then with continued rotation, the posterior medial corners fragment. And they went through all these type 1s and extra-articular, and there's a high percentage of these patients actually had, with those fractures, syndesmosis was disrupted in 100% of the cases. Only a quarter of them was the posterior syndesmosis. So if you have a type 1, you really have to think that you have to address the syndesmosis in this type of fracture. And that's the one that sort of had the highest percentage of syndesmosis disruption. The type 2 and AB were the sort of the ankles neutral to plantar flexion, the tail's loaded, and the big rotational force. Depending on how much rotational force, it becomes either just a posterior or posterior medial as well. About half of these had syndesmotic instability. And a portion of the PITFL footprint remained intact, so about half in those cases. So pretty much 100% of the type 1s had some evidence of syndesmotic instability. Type 2, only about 50%, and lower when you get to these type 3, the whole posterior tibial plafond, it's more of an axial loading mechanism. And this had about 20%. So if you're seeing these fractures, and you get the fracture late at night, and you have all these, you get the CT scan, pieces all over the place. And then the first question is, how am I going to approach them? Am I going to lay them on their stomach? Am I going to do it, supine? What I usually do is I do them all pretty much straight lateral, do the posterior approach, provisionally fix the posterior pieces, the posterior medial and posterior lateral piece. I will make my medial incision. I'll rotate the ankle and try and get my medial incision and the medial piece back in place first, so I don't block my lateral piece. And I'll pin that, and then I'll come back and fix the lateral piece. Once I fix the lateral piece or pin the lateral piece, then I'll fix the fibular fracture. I don't think it makes that big of a difference. As long as you have fixed the posterior lateral piece, and you can go and usually fix the fibular fracture through the same incision. A posterior plate's nice in that location as well. So pin, If you can pin fix medially, because it can block your reduction, I've been through that a couple times. Just couldn't get the piece back there because I was trying to get the lateral piece first. So I will expose the lateral piece first, but I'll rotate over and try and pin that medial piece. And we know that there's another good study in foot and ankle. They decided to position them either supine or prone. So if you're positioned supine, whether you needed 48% needed some additional stability of the syndesmosis. But when they position them prone and they fix the posterior malleolus, syndesmotic stability is restored 97% of the patients. So if you're going to go supine, you're more likely going to do some sort of syndesmotic fixation because you're not going to address the posterior instability. So don't be afraid to go posterior in these patients. And I don't think it matters, and there's been good data backing up whether you do a screw or you do a plate. Anatomic reduction is what you need. Another good article came out again. If you want to read two articles, both were by authors. One was 2017, 2018. The other one was about the size of the posterior inferior tib fib ligament, and they matched them to their fractures, and they felt that the ligament is so big that if you're getting instability, it's rare to get instability just from the fracture site, that you probably have a ligament tear too if you're getting syndesmotic instability, because if you look on the slide, the blue and red are the size of the ligament. Most of the fractures don't go up that high, but so you'll get a fracture, but you also get a tear of the ligaments as well. So we try and fix posterior. So posterior stabilization is one of the sort of the really things I focus on when I treat these patients. We know that syndesmotic stabilization doesn't provide posterior stabilization, so you just can't put syndesmotic screws in to fix the posterior fiber. We've seen some of the worst ones I've seen have been this sort of technique. The other thing that comes up a lot is how far up do we fix a fibular fracture? Clearly, I don't fix this one up top or probably this middle one, but clearly I'll fix that one on the right. And I'll go about to anything up to the distal 2/3 of the fibula. So the proximal third I won't fix, but after that I will go and fix the fibula fracture because I think it provides, first you can get the rotation down, and I think it's easier then to go distally and fix the syndesmosis. So if you look at these mid-shaft fibula fractures, there's a study out that showed you had 8 paired samples. If you just did the fibular fracture with the syndesmotic screw versus plating and screw, it was much worse if you just fix the syndesmosis and didn't fix the fibula. So it's much more stable. So mid-diaphyseal fibular fracture, we really should plate. And this has changed for the past 20 years. I mean, I have patients of mine, I'm afraid of looking back at my x-rays from 20 years ago that I would definitely just fix this with some syndesmotic screws and we would not fix the fibula proximally. So I think if you can fix the fibular fracture, I would recommend fixing the fibular fracture. I fixed that third one in. We didn't fix it. Everyone gets worried about the perineal nerve, but if you're careful, I think that careful dissection, it's not that hard of an operation. Anything more proximal, that's about as high up as I'll go. We do a lot of mid shafts like this. The other question that comes up that's for our conferences all the time: do you scope all ankle fractures? We have 12 foot and ankle guys at our and women, so now we have 2, so 14 total, I think, at our institution. I think 4 are scopers for every ankle fracture. Now the data, there's a meta-analysis, Chris Giovanni did this. It didn't show it really portends any improvement in outcome. Promise scores didn't change. Dan Fuchs did this. No change in promise scores in patients who went scoped or didn't have a scope. But you know, the real issue is if you see something beforehand, what are you going to do about it? So if I can see it, you know, if I get a CAT scan and I see an OCD, I'm definitely going to scope it. And in general, for all the professional elite athletes, I scope them before. The stakes are too high, and we've had a couple bad disasters where patients had big cartilage injuries and they were not scoped, and they presented 6 months later, and then you have no defense. And so I think the advantage of arthroscopy at the time of ORF is you can address the interarticular pathology. There's a lot of interarticular pathology. We usually go pretty quick to biocartilage to try and fix the osteochondral lesion. I think it helps with your deltoid. It can really help with your syndesmotic reduction. If you're doing syndesmosis, you can watch the fibula go back. And Sam Adams showed that, you know, that the the biology of the ankle joint's not very good. So if you wash out with a scope or you just washed it out when you're doing the fracture, that improves the biology. Now, Jim Nell will tell you that if you have a bimal fracture, they could see, I think, 85% of the dome of the tail, so you didn't need to scope it. So there's the argument there. The disadvantage is increased operative time. Some of these ankles are very swollen, then you probably add a little bit more swelling. And then really, for me, it's the position. If I'm going posterior, then I'm in a lateral position, and they have this big posterior thing. Do I really want to put a scope in there and twist, bring the ankle over, rotate it out, and do a scope at the same time? So this is a nice article from Sam Adams about that confirms that we should lavage these ankle fractures. Return to sports is really hard to determine. There's really no good data about elite athletes return to sports after ankle fracture that I know of. The problem is a lot of these fractures occur during the season. The player that misses the season is out for the rest of the season, and then they come back the following season. So when do they actually return to sports? It's hard to tell. Which sport, which position makes a big difference as well. And so in general, I tell patients with an isolated fibular fracture, we've had patients back at 6 to 8 weeks, clearly back fully playing professional sports at 6 to 8 weeks. Some have been back a little quicker. The bimal or trimal fractures, I tell them 5 to 6 months. I think that's when they return, even though if we rate them very quickly, I think that's a realistic thing you can tell your patient, even elite athlete, it's 5 to 6 months before you return to sports if you have a bimalar or trimalar ankle fracture. So in summary, fix everything, especially posterior. I think it really helps your reduction. And I think that is sort of what we've been focused on at our institution in treatment of these ankle fractures is going posterior and trying to fix that. Thank you.
Good. Well, thank you. Marty, that was a great lead into what I'm going to talk about. Can't agree with you more on so many of the points you made, particularly the value of arthroscopy. When we talk about ankle trauma in our athletes, perhaps we aren't changing the prognosis in some of the issues we may see with the scope, but certainly it's helpful to document with the arthroscope, but also to help to identify some of the subtle ligament injuries that may occur with ankle trauma that otherwise might not be picked up. So that was a great lead in, and I'm going to talk about this medial-based ankle trauma issues that we're currently seeing in our athletes. You know, as Marty said, I know that Kirk's going to talk about it as well, syndesmotic injuries don't oftentimes occur in isolation. When we deal with high ankle sprains, Weber C injuries, Mason fractures, it's not just the syndesmosis that's injured. You got to consider the deltoid that's also maybe injured. This combination is persistently common. Perhaps greater than 10% of all of our ankle sprains have this combination, you know, and one that we need to be cognizant of because there's a very high instance of these high ankle sprains occurring in all sports, all field sports, particularly the NFL. And certainly there's multiple factors for this combination of syndesmotic deltoid injuries with or without fractures. And it's this whole cleat-turf interaction that we're currently spending so much time with, trying to figure out the balance of torque versus traction and the effect of rotation on that. Extra rotation mechanism is how most of these ankle injuries occur when we see these Mason, high ankle sprains and such. Again, extra rotation is a constant. You'll see this defensive back in that video there on the bottom where he gets a contact injury, valgus thrust to the right leg, and foot gets caught up underneath, caught on the turf, and he gets an extra rotation with minor eversion component. And this is the mechanism we're seeing with so many of these ankle injuries, is this extra rotation injury that can lead to the Mason, the Weber C, the high ankle sprains with syndesmotic involvement. But it's not just the lateral side that gets injured, it's the medial side as well. The NFL has spent a lot of time and money looking into the high ankle sprain and some of these extra rotation injuries. This is just an example of a cadaver set up at the University of Virginia laboratories that was done to find out exactly how ligaments rupture, when they rupture, when you apply extra rotation to that fixed foot. In this particular study, the fibula actually failed at times prior to the posterior inferior tib fib ligament and created a Weber C type of fracture pattern, which again, we see so often clinically. We took that cadaver information and then did computer modeling. And you'll see here very nicely the computer modeling of these extra rotation injuries. And if you look here on the far medial one, you'll see that what happens first is a superficial deltoid ligament, the anterior capsule, the spring ligament complex, is what eventually gives, it eventually does have a significant amount of force applied to it, and then those ligaments basically fail first as the foot rotates externally, and then you then get the anterior inferior tib fib ligament. You then get the syndesmotic injuries. You get the interosseous membrane injuries. You get the posterior elements that are injured, and then you may fail at the bone level, either at a Weber C or Maisonneuve level of the leg. So depending on how proximal it goes. So again, this information was extremely valuable to me because it showed me that with these external rotation injuries and the ones that Marty just showed with the fracture laterally, you got to consider that these injuries begin on the medial side. So again, always got to keep that in mind, what's going on the medial side as you manage your lateral-based bone injuries. Now, when you evaluate the medial side of the ankle after ankle trauma, particularly in the athletic individual, you start with plain radiographs, and some are very obvious. You see that radiograph there on the far left, and you know this person obviously has a significant deltoid ligament disruption along with your syndesmotic and interosseous membrane ligaments. And then you do a stress radiograph, you see there on the right, and you again see that that is grossly unstable. So some are definitely obvious, but some are not obvious, and you need to go and you need to assess for stability, both on the medial and the lateral side. So we all concentrate on what's going on laterally. There's the fracture. We see the syndesmosis. It looks disrupted, but don't forget about checking the medial side. So we start with radiographs. We start with standing radiographs if it's feasible based on pain. If it's not feasible the first week, we might do it the second week when they can go ahead and stand on a single limb to accentuate areas of diastasis and instability. So again, you're looking for, is there increased diastasis at the syndesmotic level? Is there an increased medial clear space? These are the kind of things you want to assess on your radiographs. But as Marty said, I'm very lucky, just like he is, to have a weight-bearing CT scan in my office. So I can have these individuals come in and then do a weight-bearing CT scan, again, within the limits of their pain. But this is very helpful in detecting mild diastasis or subluxation, both on the lateral side, on the medial side, and as Marty said too, we've picked up some subtle posteromedial fractures as well, utilizing this, this modality. So again, very, very valuable device imaging study to highlight some areas of potential subtle instability or occult fracture formation. So you go, well, who cares? Why do we care about medial side pathology and the potential instability? Well, the concern that we all should have is that if you fail to recognize medial instability, it may lead to chondral injury and eventual DJD. We see so many athletes in their 40s and 50s that have developed horrible traumatic arthritis of the ankle. Perhaps these are individuals where we failed to identify medial instability and treat it initially. So again, we need to really be concerned about whether or not there is medial side pathology and instability. And the question then comes down, well, how do we do that? How do we take our athletes with potential medial instability along with lateral pathology, those particularly with Weber C syndesmotic injuries? How do we identify instability, and then what do we do with it? So again, it's a difficult question to ask and to answer. We oftentimes rely on MRI, but you got to be careful with your MRI. So this is an MRI study, and you look at it and you go, yeah, there's some inflammation there medially, there's some laterally, there's some soft tissue edema, you know, on basically diffusely around the entire ankle. There's been some good studies showing that the MRI is not a very reliable study when it comes to determining exactly what is injured, particularly on the medial side. So when you're looking for deltoid ligament injury based on an MRI, you might find that there's edema in the deep deltoid. You might find that the superficial deltoid and the spring ligament are very, very difficult to assess based on the cuts that you're provided. What bundles are involved? What is actually unstable? So again, MRI can be helpful in ruling out intra-articular lesions, but it may not be helpful in identifying exactly the extent of ligament damage, particularly on the medial side of the ankle. And then what it comes down to is, unfortunately, your full assessment of these individuals in assessing for medial-based instability may rely on an ankle arthroscopy. An examination under anesthesia with ankle arthroscopy is probably the best diagnostic tool we have, and you'll see then the video there on the right of a grossly unstable medial side of the ankle joint. And there's been articles showing that it's far superior to fluoroscopic stress testing or MRI evaluation. So what the arthroscopy does under anesthesia is it basically highlights areas of instability. So this is our deltoid instability test, medial stability test. It's an anterior drawer with external rotation. So anterior external rotation, you'll see the gross instability there along the medial aspect. And it's a totally different exam with the patient asleep, relaxed, than it is in the office setting. I have a hard time determining whether or not somebody's unstable medially in the office if they're tight, they're large, they're restricted. But yet you put them to sleep, you put a scope in there, and it's a totally different world in regard to proper evaluation. And again, supporting what Marty said before about the value of arthroscopy is multifactorial, but this is certainly one of them. So, okay, so you determine this person has medial instability. Now what do? You fix the deltoid? You know, I was taught back in my residency and early training that the deltoid was a mid-substance rupture, did not require repair. It will heal like an MCL of the knee. You know, don't worry about it. Just let that thing go. It will do just fine. Well, I may still not fix deep deltoid ruptures acutely unless it's an avulsion off the medial malleolus, but the superficial deltoid injury is much different. And that's the one that's created by the external rotation maneuvers that we showed before in the videos and by computer modeling. So again, when you have these external rotation injuries that result in the lateral base or the posterior malleolar fractures that Marty talks about, they also can be in conjunction with superficial deltoid injuries. And again, different than the acute deep deltoid ruptures that we may still wish to treat non-optically. I think you got to be very wary of these superficial deltoid injuries. We need to be cognizant of them and perhaps be a little bit more aggressive with treating them acutely. Now, again, this is a controversial subject, but if you look at our articles out there, they're very dated. The first article was 1988, saying you don't need to do a surgical repair for the deltoid ligament, acutely or chronically. Down below, you see the one by Michelson back in 1993, who actually brought this topic to a head and said, perhaps we're underestimating the value of the deltoid. Perhaps we should go ahead and fix them. So again, controversial subject, but I've had my paradigm shift over the years. I was concerned about chronic medial instability and pain. I started opening the medial side of all my high ankle sprains, Weber CMAs, new fractures back in 2004 and continue to do so, particularly in young, healthy male athlete individuals, because what we're finding is that they don't have a mid-substance rupture of the deep deltoid. They don't have an unoperable lesion. They actually have an avulsion of the superficial deltoid off bone that is repairable, as I'll show in a second. And I don't see a downside of making a small anterior medial arthrotomy. I think it has a low morbidity. And I think that fixing the deltoid further supports and protects any lateral-based injury and fixation, as Marty just nicely outlined. So again, it's sort of a belt and suspender type of mentality. You fix the lateral side, but you fix the medial side, which gives further support to the lateral side. So we started opening these up, and this is what we found. This is our anterior arthrotomy, and it's not a mid-substance rupture. This is a cup avulsion of the superficial deltoid with its extension of the spring ligament and the anterior capsule. And this is amenable to direct repair. So again, this is something we saw time and time and time again. These are Weber C, Mays-Noops type injury patterns. Even the one at the bottom is a Weber B. But you'll see here when we open them up medially, it was a complete avulsion off of a denuded anterior aspect of the medial malleolus. So you had this deltoid complex avulsion. We went and we fixed them laterally. We did everything that Marty said, just fix the fibula, you put your synospinal fixation in, but also we addressed the medial side. We found the avulsion and we denuded the anterior aspect of the medial malleolus. We put an anchor in and we advanced the superficial deltoid complex back to bone. We were able to get enough of these numbers to actually generate a paper out of this back in 2015, again, showing this consistent pattern of superficial deltoid ligament avulsion with these lateral-based external rotation injuries. So again, something to consider. And this is amenable, as I said, to open direct repair. You go ahead and you denude off the anterior aspect of the medial malleolus, and you do what we call a medial brostrum. You're basically using an anchor and you're doing a horizontal mattress advancement of that avulsed or attenuated superficial deltoid ligament complex back to bone, securing it in dorsiflexion and some internal rotation. So I just think you need to consider the fact that these medial instability patterns oftentimes occur with these external rotation injuries, but other ligament issues as well. Hinterman and also this paper down below out of Utah showed that a lot of our lateral ankle instability patients have a component of global instability or medial ankle instability. And one reason some of our lateral ankle reconstructions may fail is failure to recognize the presence of medial instability as well. So again, just something to consider is that medial instability is probably more common than you may have thought. And this is not just football. This is not just field sports. We're seeing this even in other sports. This is a 30-year-old NBA player with a Mason-New fracture. You'll see there's the MRI showing a lot of swelling there medially. Again, hard to define exactly what's going on with the deltoid, deep or superficial, but certainly there's an injury there. This is basically a stress radiograph showing that he's grossly unstable. And then this is, again, the video I just showed previously, the huge cuff avulsion. So again, now this is amenable to direct repair. And then also, not only do we repair the deltoid, then we do go ahead and place syndesmotic fixation here to provide additional support to the whole complex. So as a result of all of this, I basically open every deltoid in the athlete with a Weber C, Mason-New fracture, unstable, syndesmotic, or high ankle sprain type injury. I just think the morbidity is low, the advantages are great, and it may help long term. Again, our goal here is to avoid chronic medial ankle instability. Again, this is an example of a running back, Pro Bowl running back, who basically had medial ankle instability patterns in conjunction with syndesmotic injuries, failure to recognize he has this so-called corkscrew phenomena where he's been trying to rehab on an unstable medial aspect. He's been grinding down his lateral talar dome. So again, this is a concern, and failure to recognize medial instability acutely may result in these chronic medial instability patterns, and then again, chondral injury, joint destruction, traumatic arthritis, and poor results at a younger age. So again, please consider this medial instability pattern in conjunction with these other ankle injuries. Very briefly, Kirk just wanted me to just mention this because it is medially based as well, as is the medial malleolar fracture that we see in our athletes. And understanding what is a stress fracture and what's an acute fracture. You look at that fracture there and you go, yeah, it's a medial malleolar fracture, acute medial malleolar fracture, we'll just treat it like that. That's not. That's a stress-related fracture. And these medial malleolar stress fractures are bad actors. They often present very indescriptibly, vague symptoms, and actually your radiographs, when you first see these people, may be indiscernible as far as a fracture line present. 50% are not visible on plain radiographs of presentation. If you are lucky to see one, these fractures are oblique. They're vertical fissure type of fractures. I call them the vertical shear fracture that extends posteriorly. And if you suspect one, just like Marty said about the value of CT scan with acute injuries, if you suspect this, get a CT scan. CT scans highly recommend right away, once you suspect the diagnosis, to not only look for is there a fracture line present, but its position, its extension, and whether or not there's any associated cystic or lytic lesions that may imply that it's been there for a while. When I recognize one of these, I have a very low threshold to immediately fix them, even if they're non-displaced. And my go-to fixation option is the anti-glide plate. So again, that's our typical configuration you see there on the bottom right for a fracture that you identify as above. And when you go and you fix them, that open arthrotomy, that open approach to the medial malleolus also allows you to remove any impingement lesions over the medial malleolus, the medial gutter, the anterior distal tibia, or the medial talar neck. Because again, that may be the pathognomonic lesion, is the impingement of osteophytes on the talar neck and the medial malleolus that then puts a tremendous amount of stress on the medial malleolus. So when you're there, go ahead and debride any impingement lesions at that location. And I think the most important thing is go slow with your post-op. Get a CT scan at 3 months before you let them do too much. You got to ensure union before proceeding with loading activity. You'll see there, I would not be happy at 3 months if I saw that particular CT scan. I think that person needs more time or additional augmentation or something. Now, even after they're fully healed, they still will have a joint surface defect, a small one, that should not be of major concern, but you just don't want to see that extension persisting. This is just a quick case to finish on. This is a 20-year-old quarterback who was treated as an acute medial malleolar fracture with these 2 percutaneous screws that were not even placed perpendicular to the fracture itself. He came in at 4 months after fixation, was told he was healed, but he had a lot of pain when he did inversion maneuvers. We did a CT scan and confirmed a delayed or frank non-union. Took him to the operating room, and more concerning was the fact that he had screws in his posterior tibial tendon. So again, when you take on these patients, beware of using percutaneous techniques. You got to know where your anatomy is. You got to avoid the posterior tibial tendon. But also, I think you want to do the right kind of fixation. So in this situation where we saw that screw going directly through the posterior tib create a lot of problems, that was one concern. We had to go in there and debride and fix the posterior tib, but also we had to change all the hardware to something that was more conducive to this vertical shear type of injury, chronic non-union, that is the anti-glide plate. Fortunately, he did have a good outcome, was able to return to sport after 4 months post-op. So again, just to highlight some of these things on the medial side of the ankle that go in conjunction with what Marty talked about laterally. Thank you.
As we know with syndesmotic injury and its prevalence, this is something that occurs frequently in athletes and most commonly in collision sports, particularly cleated type sports, which are relatively uncommon otherwise though in the normal population. Certainly see it a lot in Division I football and Hunt's study that was published in 2013, and that noting that even in Nussbaum's review 2001 in HSM that it rises up to 75% in these athletes compared to normal population in sports. Just very briefly, as far as the background, we know it's a ligamentous complex consisting of these four: the anterior, inferior tib fib ligament you see here, and the posterior complex, which includes both the transverse tibiofibular ligament and the posterior inferior tib fib ligament, which makes up 42% of this. And then finally, the interosseous membrane. As far as the biomechanics, the shape of this varies, but typically it's concave, but not always. And that certainly matters as far as how we try to fix it, particularly as we're trying to reduce it and clamp it. And then also then in considering this, we have to realize that it's a mobile and not static joint, and it widens during gait and rotates, moves and slides posteriorly. As far as the mechanism of injury, just as you can see there, as far as that foot and the cleat kind of planted against the surface and the body rotating relative to that, this is external rotation mechanism that both Marty and Bob have so eloquently described. And knowing also that while it doesn't have to be a dorsiflexion position, certainly the dorsiflexion of that wider portion of the talus coming into the mortise brings that to where it's much more easy to generate a stronger and more significant force against that syndesmosis and across this joint. You know, this is once again these 3D modeling images that the folks at UVA were able to generate for us. But what we understand is that this is a 360-degree complex. This is not simply just the fibula and the incisura laterally, but also the deltoid. And as Bob has also described, concerned that a lot of times that superficial deltoid is one of the initial structures injured. And in considering fixation of these, particularly when they're larger mechanism injuries, this must be addressed, particularly when it's a periosteal sleeve avulsion, as discussed. As far as the diagnosis, this is sometimes one of the harder things with the more subtle injuries to assess, particularly if they present to us off the field and at a later date. External rotation mechanism is suggested, but not always present. You must evaluate the entire extremity, as Marty discussed as well. The squeeze test, which is being seen here, which can, when generate tenderness and pain along the anterior aspect of the distal syndesmosis. The external rotation stress here that's shown, where we're replicating a lot of times the pathomechanical mechanism of how this happened. And then also looking, besides tenderness is present, is there tenderness medially? And then even as was shown here, as Ned Amendola described in one of his publications of this approximately a decade ago, the syndesmotic taping test. Definitely not something you'd want to do acutely with any athlete, but particularly in the concern for a chronic syndesmotic instability setting. The ability to do this and perform this test and all of a sudden take someone who has difficulty with performing a single limb heel rise and then seeing that with that circumferential stability of the syndesmosis with that taping test, amazing how a lot of times you can resolve some of the pain in doing that, although certainly have to do it for a very limited time period. As far as imaging, obviously X-rays, looking for those posterior malleolar fractures, as Marty discussed. You know, the whole idea of the 25% when you're trying to think about syndesmotic instability is not relevant. Any of these injuries in the back, I would argue, as he did, are concerning as far as stability, and certainly any of the proximal fibular fractures as well, as you can see in those images. CT scan is definitely useful, particularly weight-bearing CT and the advent of that and being able to detect diastasis that's undetected or maybe not as appreciated on plain radiographs, and certainly is much more sensitive than X-ray, particularly in a weight-bearing fashion, at a much lower amount of diastasis or change, particularly compared to the opposite side. Similarly, MRI, while sensitive to injury to the complex, definitely used to not only look for the injuries laterally at the syndesmosis, but also medially, as Bob discussed, and how critical the deltoid can be in trying to maintain integrity of the ankle. In chronic ones, though, especially when there's been some calcification and this is a recurrent injury, it can be more difficult, but you can look at things such as edema within the FHL muscle belly or the sheath, lateral subchondral edema that can sometimes unfortunately be present when these are more chronic and unstable, to where it's getting some of that lateral chondral wear or overload that Bob discussed, as well as some traction edema medially within the medial malleolus. But have to remember that this is not a stress test, and it's certainly not predictive of return to play, as has been borne out in the medical literature. I like Dr. O'Malley and Dr. Anderson, believe that arthroscopy is the gold standard in being able to determine this, and Liu et al., in looking at simple Weber B and C fibular fractures, certainly showed how this was much more sensitive than intraoperative fluoroscopic stress. Takau's study also further noticed this as well. And then even in our multi-center study of the arthroscopy of the ankle and foot, we're seeing that this is once again bearing out frequently in otherwise fracture patterns we would not consider to be inherently unstable at the syndesmosis, and that a proper identification and fixation of those, as you can see there, is critical. This is what I'd refer to as a medial drive-through sign. There should never be a situation where you could take a 4mm shaver like you can see here and be able to drive that into the medial gutter. If you can, I would argue that's representative not simply of just deltoid instability, but certainly lateral instability of the syndesmosis as well, to allow that talus to shift like that. Similarly, the ability to take that same shaver or probe and introduce it into the syndesmosis is not normal and is indicative, in my opinion, of something that would need to be addressed. As far as the current algorithm in working this up, the inability of the athlete to bear weight, the one that has difficulty walking off the field or the court, pain with external rotation stress, tenderness to palpation along that syndesmosis that is 4 or 5 centimeters or greater above the ankle mortise, the mid-tip fib squeeze test, plus or minus whether they have that deltoid tenderness palpation. If you're seeing a majority, routinely ones that I will get an MRI to be able to better assess. If based on the mechanism and some of those history, as well as in that MRI that demonstrates potentially an AITFL only injury, there's no diastasis or symptomatic instability, you certainly have to set a course of expectations that's going to realize not a simple ankle sprain, whether that's discussing it with the athlete, the trainer, their family, or the coaching staff. They can come out of immobilization or that boot for range of motion once that external rotation stress is negative, but you have to be very careful that unprotected weight bearing and a too early return to play can start that entire process all over. And you can begin proprioception retraining and strengthening once able. Bob has talked routinely about the single limb hop test as a great functional stress to be able to see whether these athletes are ready to be able to start to progress with their return. And with the only injuries, Amendola demonstrated how an 86 to 100% excellent income or a good outcome can be expected when it's this isolated AITFL only injury. Going down to the very last one there, certainly the 3+ ligamentous and or fractures that Marty discussed, those are surgical stabilizations in every case. The problem becomes these 2 ligament type injuries, which are the most controversial. These are the classic grade 2s. These are the ones that are the most difficult, and sometimes it's hard to fully appreciate grade 2 compared to maybe that isolated AITFL only. Sometimes it's the failure to progress that may take you to this. But with these, I used to recommend an EUA and a fluoroscopic exam under anesthesia as a minimum. And if that EUA showed asymmetry, then obviously a diagnostic scope stabilization. I would argue now that the ability to use this small bore needle arthroscopy or a standard scope, especially when these notable MRI findings are present, like you can see there, where you have this superficial deltoid that you can see is no longer in a linear fashion, but instead is starting to coil up. That is never a situation that's normal. Or when you start to see this posterior malleolar avulsion type edema and irregularity of the posterior inferior tib fib ligament, those are always concerning. And then ultimately, a lot of times, this is what you end up seeing arthroscopically, where you're seeing that chondroosseous avulsion of the posterior inferior tib fib ligament that I would argue must be addressed and stabilized. As far as treatment, there were plenty of screw fixation debates as to the size and the amount of cortices that should be crossed, when that should be fast it should be removed, doing it too early, realizing that you lose reduction. and also the difficulty in being able to get a congruent reduction when you use a static fixed device. We know that fixation matters based upon the classic Ramsey and Hamilton study looking at pressure related forces across that joint when it's incongruent. This was then reproduced even more recently in October of 2006 by Lloyd. And we also know that that malreduction is underappreciated on X-ray, certainly more appreciated on CT, and that the only significant predictor of functional outcome is that anatomic reduction of the syndesmosis, as Weaning showed in the Journal of Orthopedic Trauma in 2005. For me, and I think the other presenters, at least as far as in most routine cases, this is a suture button type fixation with a knotless design for that motion of this joint that has inherent motion to it, as we discussed previously in the background of it. And there's numerous studies supporting the use of that. And as far as looking at some of these high-level studies, these are some of the more recent ones in 2018 and 19. This was the Anderson et al. Study in JBJS, a level 1 randomized controlled trial that showed that tightrope compared to screw certainly was less malreduction and minimal concerns for recurrent diastasis and functional outcomes that were superior at 2 years. Looking then at the Canadian Orthopedic Trauma Society, including Sanders et al., their level 1 prospective randomized controlled trial, this was looking once again at these outcomes. That malreduction was less, reoperation was significantly less, as was unplanned reoperations. Once again, the ability for this to hold and maintain that anatomic reduction. As far as 1 versus 2 tightrope, when using them in a divergent fashion, it can elicit a little bit more stability of this rotation. But in thinking about this, there's also a consideration, especially when you have an avulsion fragment off of that anterior portion of the tibia or the flagstaff tubercle of the fibula. Using an internal brace type of suture tape device over this can provide time zero stability of that with a tight rope back and behind. That is another potential way to be able to stabilize this. The importance of it being, though, the key, especially if you're going to weight bear these patients early, that this appropriately addressed. So my current treatment is an arthroscopic evaluation to identify subtle syndesmotic disruption or instability, fixation of fractures if present, fix the fibula, just like Marty said, unless it is incredibly proximal to set that length and rotation. Posterior malleolus must be fixed. If it is just a very subtle avulsion that is seen arthroscopically, those can simply be treated, in my opinion, with dynamic stabilization. The syndesmotic fixation, 2 tight ropes for the majority of these, or a hybrid construct where you're using a screw and a tight rope. The screw can then be removed once they start to do significant weight bearing. The deltoid, very important, as Bob talked about, repair that superficial avulsion, and you can identify that arthroscopically. And the other important consideration, as you can see there, is the use of the buttress plate, particularly in a contact athlete, or if this patient, for whatever reason, not an elite athlete, is necessarily going to have poor bone quality. You must stabilize that and protect it, as you can see from this picture, because certainly when these are contact athletes, you must avoid that complication that you can see right there. As far as the whole TUA effect, we can't avoid this now that certainly this is out in the public domain. But the reality is we've known about suspensory fixation for a long time. This does not automatically mean that every syndesmotic injury needs to have tight ropes placed to stabilize them. But the important thing that we need to be able to understand is being able to further understand and study the ones that we can better identify as those grade 2s that may be unstable compared to the grade 1s, and certainly manage expectations of this, both with trainers as well as the players, some of their support staff. Once again, can't underemphasize or can't overemphasize enough the importance of that superficial deltoid, realizing this is a 360-degree complex that must be stabilized. So in summary, this is a common and difficult injury for cleated athletes. You continue to need and demand improvements in the diagnostic criteria, because I would argue that a lot of these still see us more than we are seeing, although I think we're better than we were, and weight-bearing CT is probably a better way to be able to understand these. The management is still very controversial. Might there be a role for MR arthrography? Or I think there definitely can be a consideration from that. And as far as dynamic fixation rather than static fixation, facilitate ligamentous healing and obviate the need for hardware removal, and repair the medial side when significant injury is present.
There are some questions there, Kirk. I don't know if you can see them. Maybe we can hand this one to Marty. There's one on what's the role of the fibular nail.
Oh, I love the fibular nail for the older patients. It's my favorite thing for the diabetic. I've been doing I've been using a Jones screw for many years on that as well for some of the older patients before they had all the fibular nails. I'm just not that comfortable doing it with the athletes yet, but I imagine it would be a quicker return. I'm just a little concerned. Most of them have the syndesmotic fixation with screws, and I'm usually doing it in when I'm really concerned about putting screws in, leaving it unstable fracture, poor bone quality. I still think my results would be better without the IM rod in the athlete. But it's a good question. It's sort of that's the next step in treating these fibular fractures, where the role of the IM rod fits in the younger patient.
Bob, is there anything else you can see there you think we should address now? I can't see them currently.
Oh, there's another one for Dr. O'Malley. When you fix the posterior malleolar fragment first, and then the posterior lateral fragment, you're using both posterior medial and posterior lateral incisions at the same time, or are you reaching over medially with the posterior lateral incision? So when you do that, Or you do what? I'm sorry?
I definitely do 2 incisions. I rotate the leg. I spend a lot of time with how far lateral I get them and make sure they can external rotate their leg. And it's hard, but I'll get it provisionally fixed laterally. Then I'll fix it. The final fixation will be after I let the beanbag down and I've fixed everything laterally and I've just rotated the leg out. I'm just trying to get a pin so I don't block my fibular fracture, my posterior lateral piece.
So, Kirk, here's another really good one. I'll voice in on this because I've got an opinion much like Marty, and I'll just reiterate what he said. The question is, did you say that you would fix all proximal third fibular fractures with syndesmotic disruption? So we can go back to that. I personally do not fix Mason-New fractures. So fractures in the proximal 1/3, I am very wary of going into those, creating this huge deep well where you really have a hard time identifying the perineal nerve and then fixing them. And I have seen a number of athletes with foot drop after people have tried to fix proximal third fibular fractures, even with distal pathology, syndesmotic disruption and such. Now, while I say that, I think it's also mandatory to anatomically reduce your syndesmosis distally. So I will do an open reduction of my syndesmosis distally, may even use a screw if I have concerns about shortening or rotation proximally, in addition to a tie rope like the hybrid model that Kirk just showed. But again, I'm very wary of doing an open reduction to fixation of a Mason-New true proximal fibular neck fracture. So Marty, I guess the question was, is that what you were saying as well?
No. The proximal third, anything past that. So the distal 2/3. My point is, I go mid shaft. I'll go up a little higher than we used to. I won't do that really proximal third one. And I agree with you 1,000%. If you have an offensive lineman that you're trying to fix his proximal fibular fracture, it's like you're in his thigh, a regular person's thigh. And
exactly. So you're not saying you're not fixing fibular neck fractures. You're not fixing.
No. I'm just saying I'm fixing higher. I don't think there's a role.
I'm the same way.
Yeah, the mid shaft ones. Yeah.
Okay, good. Because I'll fix mid shaft as well. I think that's helpful. And then I try to have a plate that's long enough where I can put my syndesmotic fixation through it distally. But yeah, okay. You and I are both saying the same thing. Do not fix proximal third fibular fractures.
Yeah, and I would definitely concur with that as well. Let's see here. If there's not any other pressing ones, Bob, this was one of your cases. Why don't I have you kind of lead us through what kind of a discussion this stimulates?
Yeah, this is just a follow-up of the same thing we just talked about. This is a very Dr. O'Malley and I share a number of patients, and this is sort of a classic that we see all too often. 21-year-old pro basketball player, a big guy, small feet. He's got mild cavus. He comes in and he's got some just vague medial right ankle pain. And you take this x-ray, it looks normal. And the question is, you see this and you go, okay, how aggressive do I need to be? So Marty, you get a guy that's that player, that size, medial ankle pain, mild cavus. Maybe he's got a little positive percussion test over the medial malleolus, but x-rays are normal. Do you image him right away?
Absolutely, get an MRI because I've missed so many of them. The patients
so-
I've had so many have walked in the door who've been sat on for a couple of weeks with their normal plate X-ray and have come in with that big fracture line you showed before.
All right. So, Kirk, you have to advance that for me.
Absolutely.
Okay. So he continued to play, pain after every 10 to 15 minutes segment that he got involved in, he had pain. No swelling, persistent medial pain. There's your MRI.
Yeah, and so
I think you're going to advance that one, Kirk.
Yeah, and here I think becomes similar to when we see all that edema within the navicular. I think you can see that probably early on a CT scan, where otherwise it just looks like a bomb went off there on the MRI. CT scan might avoid that.
Yeah. So the question is, the MRI shows all that edema in the medial malleolus, and maybe you get a CT scan. This was done overseas. Maybe get a CT scan to look. I would get a CT scan to look for fracture. I do not believe that was done. But the question then for you two is, how aggressive are you when you see edema in the medial malleolus without a CT scan showing obvious fracture? Do you consider prophylactic treatment? Do you just shut them down?
I would consider prophylactic treatment. And actually I have a couple patients who I've done a percutaneous plate, made a little incision over the tip of the medial malleolus, run up and put a couple of screws in the antiglide position and a couple distally. And then when I go to sleep at night, I feel much better.
And I think the point here was that if a CT scan shows a fracture, obviously you're definitely going to fix it. You should at least shut them down. I think you both would agree. At least shut them down.
Yeah, no, absolutely. Yeah.
The problem is, Bob, if you shut them down, how long do you shut them down for? Then the edema is going to be there at 6 weeks on the MRI. So if you can do it, if you can do it with, some support, if you make a little incision, run the plate up there, a couple screws in the medial malleolus, I think that it's a more predictable return to play, because the reason he has this for these stress fractures, there's a reason. It's his mechanics. And so you haven't changed, unless it's, he's never played basketball and now he's coming back from some injury and he's up to his activity. But there's a reason he has it. And it's most likely for these medial guys, they either have the anterior medial impingement or some cavus foot. And so if we don't change the cause of it, it's going to come back. So I'm not
disagreeing, but
for me, this is the one go ahead. This is the one that I feel like it's
just don't let them keep playing on what you see.
Yeah, no, not at all.
And also repeat your CT scans often, because what may not show initially, 3 weeks later, you may all of a sudden have a fracture. But at any rate, for the sake of time, he was overseas and they placed these screws. You can see they placed the screws.
Yeah.
And pain persists after 5 months. Now what? Well, you got to keep up with these CT scans, because you can see the CT scan. If you look down on the lower second from the left, you'll see he's got a fracture that's propagating again right through that. Yes, thank you. Right through that distal tibia rising out of the medial malleolus.
He has that area to see this beaking where he's been trying, as far as a periosteal reaction, it's been trying to heal. And I think whenever you can see that, even if the crack hasn't, maybe if you only had this and you see an anterior impingement lesion and he's mildly cavus, I mean, that's the recipe for disaster with that, I think.
Yeah, and if you go back one on that too, Kirk, you'll see again, I just think, and I think you two would agree, go back one more, that that's just not the right fixation for this particular pathology. So this is not a medial malleolar fracture. This is a medial malleolar stress fracture, vertical shear, tremendous amount of stress on that segment. You really need an anti-glide plate. So at this situation, again, you can advance 2, and you'll see that this is, I don't know what you all use, but this is our sort of go-to as a anti-glide type of plate with removal of the impingement lesions.
Yeah, I mean, I completely agree. Marty?
Absolutely. We have a series now. I think I have 9 of these in the professional basketball players. They are
Go one more. And, I just wanted to bring this up for the audience too, is that you know, there he is. He looks great, but non-weight bearing 6 weeks, boot for 6 weeks, CT scan there at 12 weeks, looks beautiful, looks fantastic. But these, just like navicular fractures, are very, very humbling. So all of a sudden now you got him back playing professional ball, has a mild twisting injury. He comes back with vague medial ankle pain 6 months post-op, and now you do the CT scan, and again, a very humbling situation. You can see the recurrence on the anterior aspect. And again, we've all been here. These are unpredictable, yeah. And the question now is what do you do at this point? And there are no really great answers.
And both of you have certainly outlined whether it's this, whether it's navicular fractures, you've got someone at this high of a level, and now you've had all these repeat injuries. I mean, this is where a specialist, I'd never feel comfortable doing this on my own, but this is something where you wonder if you need something like, you know, in addition to, you know, what else is going on here mechanically, to try to physiologically get this thing to not continue to do this.
Oh, and he 100%.
If you click one more time, Kirk. So he did. We got him on Forteo, and he also got high energy shockwave. And yeah. Fortunately, eventually did heal and did not have to have further surgery. But again, a case with multiple lessons to be learned. Don't underestimate these. Diagnose them early. Use the proper fixation. And still, everybody needs to understand they have a guarded prognosis.
Absolutely. Marty, I don't know if you want to briefly go through this one. You had highlighted it briefly in your talk, but kind of going through.
Yeah, this is a kid who's I own a kid who's playing basketball, you know, power forward, about 6'7", 220. Big kid who just twisted his ankle, and you know, they sent it in to me just as, you know, bilateral ankle fracture. I said it was probably a tribular. So I go through the next slide. Just looking at that weight bearing CT, how to approach that, and I think then. So this is the CT scan, which shows multiple fragments medially. It just shows we got all our fixation laterally. On this one, the fibula's in a 3 or 4 pieces. Got our posterior plate. Unfortunately, I don't have a picture of us going medially first. So I have about 4 those green sheets there, and then I went over and fixed that posterior medial piece, and then with the screws up the front. But, you know, I could have placed probably 4 or 5 more plates across the medial side. Fortunately, that one plate that all sort of fit together pretty nicely. But I mean, this is the standard approach, all the way over on the side, coming back that way. And he returned at 5 months, good, then ruptures. He broke his patella, his second game back. But his ankle's great. He kept telling me. I just saw him. My ankle's
no, very good.
And I'm a little shocked.
Only just real quickly here, and then we probably need to wrap things up. But this was on Division I lineman, you know, and so as we're working through this, I definitely want the folks listening in to kind of, Marty and Bob, just to hear your thoughts. You know, with that mechanism, there's the non-weight bearing X-rays, but you know, because of the concern, I mean, here's the MRI. And kind of what any pearls you may have for folks in dealing with these. This one's a little bit more clear, but dealing with grade 2 type syndesmotic injuries, kind of what your all's thoughts are, trying to rule out the ones that need it and that don't.
So Jim Calder had that nice article. If the ATFL is intact, that's a good prognostic sign that you don't have a syndesmotic injury. So if you look in your MRI, this one, if the deltoid is out, it's 10 times more. You have 10 times more likely to be unstable. I think that was his article in the soccer players to determine whether it's a 2A or 2B. 2B meaning unstable. I will try and stand them. We actually try and do a standing rotational CAT scan if we can get them, if they're comfortable enough. We stand, we have them, their foot fixed. We compare either side and we see if we can get the fibula to externally rotate. If we get any sign of instability, they go right away. Unfortunately, a lot of these people are too uncomfortable even to complete that. Like that guy's ankle is hugely swollen, so standing is probably not with all that edema laterally. So I think the scope is take him, especially in an athlete that you take him to the operating room, you scope it with the idea that we're going to fix it. And I fixed the deltoid, and I've been fixing the deltoid since 1993. I got in a bet with the other fellow when I was a fellow about that paper, that Harper paper. I thought it was a terrible paper. I started fixing the deltoids. And then for many years, I was ostracized in our hospital because I was fixing all these deltoids. But now they have gone from pariah to pioneer, they tell me. But I think that I'd fix the deltoid, scope the ankle, fix the deltoid, and syndesmosis. I've been playing around. I like your technique with the internal brace. I think it makes a lot of sense. I think, Tom, so there's gonna be some good biomechanical data coming out that the internal brace may be a little bit better than the tight ropes, or stronger. So I think that that's sort of the future of syndesmotic fixation. Maybe that is repairing the AITFL with an internal brace, and certainly repairing the deltoid. I've seen that sleeve avulsion so many times off the medial malleolus for the superficial deltoid.
How many thoughts as you can?
Yeah, I'll make
Please.
one comment. Beware of using the internal brace for AITF injuries alone. So we have had some cases sent to us where people use the internal brace over the top, but fail to recognize there was also posterior instability, and they create an open book effect posteriorly. So
Absolutely.
again, that's an augmentation to your other syndesmotic fixation, but should not be used in isolation.
Yeah. So the question is anyone using anterior and posterior internal braces?
I have not. I've heard it done, but I'll use it with syndesmotic fixation with tight ropes and such. Yeah. But have not done the two.
I think,
but
can show you kind of this posterior chondroosseous avulsion that a lot of times is something you would not see on an X-ray. Certainly, you might see that on a weight-bearing CT. But for folks that may not have the ability to automatically get that, simply seeing the scope, you can see that, and you can also see how easy it is to take, whether it's an obturator, a freer, or a probe, and get around the medial malleolus. You should never be able to freely move that medial to that medial malleolar anterior colliculus. And then this, just like Bob showed, this is what you see. It's just this periosteal sleeve avulsion of that superficial deltoid and capsule. And to repair that back, I will, in addition to using those two smaller anchors, a lot of times will bring it up to a little knotless anchor there, so there's no knots at all, but it provides just a little bit more fixation. You can see the tight rope there, and then the buttress plate, kind of what that incision looks like there. So that's kind of how it looks. And then realizing, as far as the Gardner study is, you want to be able to center on that true lateral. Center your fixation just anterior and posterior to that, but realizing if you're just using one, right in the middle, there's the mid aspect of that incision. So that's kind of my thoughts on that. I certainly don't want to respect everyone's time, and unless anybody's got it, want to thank everyone who listened to it, whether now or recorded later, and certainly Dr. O'Malley and Dr. Anderson for all of their expertise in sharing that with everyone involved.
Thank you all. Enjoyed being participating.
Thank you very much.